we should remember that one of the biggest reasons of readmission to the hospital is congestive heart failure. And coronary artery disease is one of the leading causes of death in men and women. So the statistics are mind boggling, that's a given. Now, when we say congestive heart failure, and I'm going to talk as not so much in the scientific terms, but I'm going to put the scientific with the layman term because I think our audience is medical as well as non-medical personnel. So I will try to make it a little more simplistic. Congestive heart failure means that the heart is not pumping strongly. The heart is a pump. Actually, there are two pumps. There is the right ventricle which pumps, and there is the left ventricle which pumps. And it's phenomenal the way God has made us. It's two pumps in series, and at the same time, the two pumps are in parallel. And you would think, what physics is this? Actually, it is because the two ventricles are next to each other and they contract together. So that's a pump in parallel. But in reality, blood comes first in the right atrium, then in the right ventricle. That pumps, goes to the left side, comes into the left ventricle, and that pumps. So the series is of the blood with the oxygenation, and the parallel is pumping together. Having said that, there are multiple causes of congestive heart failure, and Dr. Suri has already gone over them. I'm going to talk about things that we can actually take care of. So coronary artery disease, which is the blockage of the arteries, which we can do something about. So congestive heart failure, let me just go over my slides very quickly. So congestive heart failure management has multiple modalities. What is a normal pumping heart? So as I told you, heart has multiple functions, the main one being pumping. So if you look at this, you have a cross section of the heart in which blood, this is the left ventricle, this is the main pumping chamber, beautiful thickness, filling, as you can see, it fills and it empties, it fills and it empties, and it's doing it at 76 beats per minute. This is normal. So if you think about your heart, it fills you and you fill it with 100 cc's of blood. It should empty somewhere between 55 and 75, which is an optimal ejection of the amount filled. That's the place where this normal ejection fraction, that's where the word comes from. So this is a normal heart, and now this is a weak heart. Look at this. This is much bigger. The cavity, this is blood, and this is the muscle of the heart, and this is the right ventricle. So this is the left ventricle. Look at how weak this heart is. It is filling, but if you look at my hands, it fills, but it does not empty. This is what it does. It's a very weak heart. And in this one, the walls are much thinner. So if you look at these walls, they are very thin. And this is called heart failure with a weak heart, as opposed to heart failure where the wall is so thick. I hope you can appreciate that the wall is so thick and the cavity is this small. Can you all see my mouse? So the cavity is very small. So it's not that the pumping is the problem, it's the filling that's the problem. And so we in cardiology years ago used to wonder if the pumping is fine. Why is this person in heart failure? So these people are called the HFpEFs. They were huffing and puffing, and they were heart failure with preserved ejection fraction. So their pumping is good, but their filling is not good. It's a stiff heart. So if it cannot fill properly, it cannot empty properly. So just for illustration, normal heart, dilated, weak heart, thick and restricted and stiff heart. All of them cause heart failure. Now, this is another view of the echocardiogram. We take multiple views. This is the pumping chamber here. This is a normal chamber. These are the valves. This is a hyperdynamic heart. You don't want a hyperdynamic heart because that leads into hyperdynamic heart failure. You want a normal pumping heart and you don't want a weak heart that you can see over here. So I hope these pictures give you some visualization. So when the heart is weak like this, we need to use different modalities for treating it and try to make this heart a little stronger in pumping. So there are multiple modalities: medication, revascularization, devices, and prevention. So the ABCs for treatment of congestive heart failure, coronary artery disease: A, aspirin, anti-anginal agents, and antiplatelet agents; B, beta blockers and blood pressure control; C, cholesterol lowering and cigarette cessation; D, diet and diabetes control; E, education and exercise. The medications, there are multiple medications that we can use in heart failure. It's a science, and then it's also an art, because you move two steps forward with a congestive heart failure patient with medications, and then all of a sudden you're 4 steps back because they did not know that the food they ate had salt in it. It was preserved, there was no salt that they added. So it's 2 steps forward, 1 step backwards, 4 steps forward, 1 step backwards. And that's why you need a whole team. You need a doctor, you need a primary care physician, the patient has to be involved, the patient's family has to be involved, and the nurse practitioner, they have to take daily weights, they have to watch what they eat, and the medications. So very important, multiple medications. If medications are not treating it, then you have to think of an intervention. You don't do an intervention if you can treat it with medicines and lifestyle changes. If take a look at this, this is a normal artery, this is a longitudinal axis, and this is a short axis. This is normal, lumen is nice and clear, and this is the cholesterol buildup. So 50% of the lumen has already been compromised. So if you take a look at this, this is the heart, and these arteries are on top of the heart. So they are called epicardial, which means it's on top of it. So if you take a look at this one going down here, it's red till here, then there is a clot. That's the blockage which causes the heart attack. And there is no blood going down here. And this portion is hurting, and that's the heart attack. This needs to be opened right away. So how do we revascularize? So I hope these pictures, visual effects will explain it to you. Let's focus on this first one on the top left. This is a cholesterol buildup, and this here is a normal artery. Blood is flowing down this way. So we can do, if you look at the top right, if you look at this, there is a wire in there and there's a balloon on it. We place it strategically and then expand the balloon and squish the cholesterol plaque into the wall. But if we do this, this is called plain old balloon angioplasty. This is what we used to do years ago. We still do it in some cases, but then the artery has a tendency to regrow the cholesterol plaque and also to collapse. So now if you look at the bottom left of the screen, this is a stent. So it's on a balloon, on a wire, we expand it, the stent is deployed, everything is pulled out, and the stent is left back. And this stent actually has a drug, and it elutes the drug constantly so that over here, these cells do not proliferate again. They are basically drugs which treat cancer, so they are anti-proliferation. So if you put a drug-eluting stent, the chances of restenosis, which is closure, is very small. It's less than 1%. So these are really very good. So we do this if the blockage is in one spot or two spots, or it's something that we can do from a percutaneous procedure. If the blockage is too complicated or there are too many blockages, then we revascularize with bypass. So look at the right bottom. Over here, it's a beating heart, and these red ones are the arteries. Let's say the blockage is here, up here. We add this vein, take it from the leg and plant it here. So we are basically bypassing the blockage. So in layman's term, if there is a highway and the road is blocked, the CHP comes and creates a detour and bypasses that blockage. That's pretty much what we are doing here. So the bypass is here, the blockage is here, and we are bypassing it. I hope that was clear in this illustration. So if you look at this, this is the angioplasty, the same thing that I showed you over here. you will see in the cardiac cath lab, here is the blockage. If you look at the top left, that's the angiogram, and you can see the blockage right there in the middle where the artery looks like it's been eaten away. And then if you look at the bottom right, the stent was expanded, the stent was expanded and it's now nice and open, right? That's percutaneous coronary intervention. Now, once we do these interventions, we wait for a few weeks to make sure that the heart muscle, which, it was contracting like this, suddenly over here, the artery got compromised. So this wall, instead of moving like this, now lags behind. Think about this. You're running a race and I take a tourniquet and I tie it tight on your thigh on the right side. Now, when you run, that right leg will lag behind. And if I tie both your legs, you will be the last one in the race if you run at all, because the legs will be so weak because there's no blood supply. Once you open the blood supply, take out the tourniquet that you have tied, the legs get circulation, and then they can run again. Similarly, when the heart has become weak because of decreased blood supply, once you do the angioplasty, once you do the bypass, whichever intervention you have done, we give the muscle time to see if it will come back. If it comes back, you have treated it and the heart has become all right and the pumping is normal. Bypass is very good for multiple vessels and multiple vessels in diabetics. Longevity of life and readmissions are much less with bypass. So it depends, the choice of the procedure depends on the patient selection, patient's criteria. Let's say the patient gets better, then you treat them with medication and lifestyle changes. Very, very important. Therapeutic lifestyle changes. However, if with revascularization, your pump is still weak, there are other devices we can use. This is called a cardiac resynchronization therapy. This is a pacemaker that's placed under the clavicle over here, under the skin, and it has 3 wires, as you can see here. 1 wire goes into the right atrium, 1 in the ventricle, and 1 goes across over here in the coronary sinus. What this device does is the heart is not pumping efficiently, and this device provides the proper electrical current mimicking the normal physiology of electricity in a heart, which causes the heart to contract. So if you have normal physiology, hopefully the efficiency of the contraction gets better. That was the hypothesis for cardiac resynchronization therapy, and it has proven to be one of a very good tool. It's proven to be one of the good tools for improving the efficiency of cardiac pumping. Then there is the AICD. You all have heard that person has congestive heart failure, they suddenly died, just dropped and died. And then you have seen in movies where they go and give a shock outside. Well, not everybody has a defibrillator here, there, and they are not doctors present everywhere or EMS personnel. So there is the small device over here called an AICD, which is an automatic implantable cardiac defibrillator. It has 2 wires. One is here in the right atrium, one in the right ventricle. Sometimes it's a single wire defibrillator, and there are other types of it. I have just shown one here. If the weak heart suddenly goes into a ventricular arrhythmia, this small little dot over here recognizes the beginning of the arrhythmia, sends a message back to this box. This analyzes it and gives it a shock and brings the patient out of the ventricular arrhythmia, thereby preventing sudden cardiac death. So automatic implantable cardiac defibrillators are an excellent device when the patient meets the criteria, they get them. Okay, now on to a completely different one. The heart is so weak that you have now got the defibrillator, you have got the CRT, you have got all the medications, the patient is following all the classical lifestyle changes, but the patient's heart is not improving and the patient is on the transplant list. but there aren't enough transplants available. There aren't enough donor hearts. So how do we tide the patient till he or she can get their heart transplant? So this device is called a left ventricular assist device. What that means is that the heart is so weak it cannot pump, but the heart is getting blood. So if you look here, this is a small tube that's placed in this pumping chamber, and this sucks out blood, and this little device here is the pump which receives blood from here and pumps it into the aorta. So this heart is kind of just a conduit, but this is what's doing the real pumping. So in the past, these patients had to be hospitalized, live in the ICU beds. They had a wall socket and they were connected to the battery and the source of power. Now they can move around, and I'll show you that. So you can have a single vessel assist device, a single chamber left ventricular assist device, or you can have a biventricular assist device, one on the left side and one on the right side. This is done at specialized centers, and people, when they get LVADs, they actually, their life expectancy improves by a few months. Actually, it's almost more than a year to 2 years. They can have this while they are waiting to be on the transplant list. Here is a person. Now he's wearing it with a harness. So up till this point, it is inside and under the skin. From this point onwards, everything is outside. So here is the system controller. Here is the battery. Here is the pump. Blood comes out here, pumps up this way, and every generator and the battery source and power source are connected to it, and the person can actually walk around, wear proper clothes, and go do something. Sometimes with the LVAD, their heart actually, with the medications and time and revascularization, they get better. Sometimes they have to go on to cardiac transplant. And that's, oh, one more thing. ECMO, this is much more newer compared to the LVADs. It's called extracorporeal membrane oxygenation. It's not that new in cardiology, but relatively against all those devices. This is for patients that have gone into sudden cardiorespiratory failure. So you take blood out, and this is not going into the heart, this is in the periphery. So you take a peripheral big vein, draw the blood out, send it through a pump into an extracorporeal, which means outside the body oxygenator, cool it and send it back. You can send it into the artery. It's called veno-arterial oxygenation. It can be veno-veno, or it can be veno, arterial, and veno. So it's going back into both, but it's pulled out of a vein, sent into an artery, or pulled out of a vein, sent into another vein, pulled out of an artery, and sent into an artery and a vein. So multiple different devices. This is to tide a person over acute respiratory and cardiac shock. And then this is the one that everybody knows about, cardiac transplant. You take the patient's diseased heart, take the donor's heart, connect the superior vena cava here, inferior here, aorta here, pulmonary here, and you have a new donor heart in place. And from that point onwards, you have a lot of post-cardiac transplant care that has to be done initially at a tertiary center, but then they can go back to their primary doctor. So that's pretty much the devices. But of course, here is the summary. It's a leading cause of death in men and women. Most risk factors can be modified. I cannot stress the importance of this. Stop smoking, treat high blood pressure, treat high cholesterol, treat diabetes, lose weight, exercise regularly, eat a healthy, balanced diet, and stress reduction. Easier said than done, but all doable. So, in summary, catch the problems before it catches you. Know your risk factors, know the symptoms, modify your risks, discuss your risks of coronary artery disease with your physician. And if you feel you have symptoms, call 911. Call 911 and come to attention right away. Rather be safe than sorry. In English, there is a saying, time is money. In cardiology, we have a saying, time is myocardial muscle. If you come with a heart attack, very quickly and they open it up, the muscle further to the blockage does not die, and we salvage the myocardium. So the sooner a blockage is opened, the better it is for the patient. So to sum it up, thank you for your time. Listen to your heart. It's telling you a lot.